thing?
My go live thing for my Instagram.
Oh.
Oh, I might need to give you a new key.
Oh, okay. We are live, however. Hi, guys. Sorry for the stodgy production. As always, it wouldn't be an episode of Taking Shots if there weren't some kind of crisis with our streaming software. So it appears that Jessica may not be able to stream right now. So tune in to...
We're going to be fine. Just sent you the key.
Oh, perfect. Okay.
Yep.
Well, we are live, in fact,
Yes.
chatting with people. So I'm going to see if I can fix that. In the meantime, Jess, welcome to Taking Shots, everybody. I'm going to let Jessica introduce our show for today and what we're going to be doing. I have some bad news in the sense that our guest, Saskia Popescu, had a change in her travel plans. And so she's on a plane right now and is not able to join us today. I am going to go do some live on-air production work. And I'm going to let Jessica introduce the topics to our show because there is a lot going on in the world of infectious diseases.
There is a lot. Welcome, everybody. This is our pretty semi-regular Friday show called Taking Shots, where we just give you a rundown of what you saw or maybe didn't see in the world of infectious diseases and public health. It is quite busy in both infectious diseases and public health. Part of that is because all eyes are on both. And so a bit of that is seeing things that perhaps not everybody would have seen. However, we are going to talk about something that is kind of shocking to even us in infectious diseases. The ongoing outbreak that has been detected in Congo right now is setting a lot of alarms off in the infectious disease community, most specifically because it got so big without it being known for quite some time. So we're going to spend about 20 minutes giving you the most recent information that we have, recognizing that it's still in a very much evolving situation. We're getting information literally as we speak. We'll spend about 20 minutes talking about that and then probably close out with an update on Hantavirus to kind of give you an update on what's going on with that. Okay, here we go. Going live to the Instagram feed as well. So yeah, Angie, looks like we are all set with all of the linked streams. So I guess we can just take it from the top and say, since we spoke to you this morning, it seems that there are now 246 suspected cases of Ebola in the Ituri province in Congo. In the eastern side of the country, there have been at least 65 deaths. It also seems like a very small number of those suspected cases have actually even had testing. This outbreak is now, if you count the deaths, over 300 people. And it's the most shocking thing about this, Angie, I think you would agree with me, is the fact that it got to this many cases before the international community was alerted. Now, it was pretty clear that the WHO received a signal in early May. It's unclear if some of the signals to others were missed or if there were earlier signals, because to get this big this fast would mean it's been spreading.
It would mean that it's been spreading for quite some time.
Right.
And if it was in early May that they first got a signal, I mean, if we're talking about more than 300 cases, Ebola can spread very quickly, but not so quickly. It doesn't spread by the aerosol route, as
Right.
I discussed this morning after you jumped off. I had a nice little soliloquy about pathogenesis. And I don't think that there is a biological mechanism for Ebola to spread from person to person by the aerosol route. And I'm happy to explain that again at another time. But, I think that for this to have spread to 300 people and for 65 people to have died of it already suggests that it's actually been going on for quite some time. And there have been these reports of people, fleeing the area that the outbreak is occurring in, because there's also major security issues and violence there going into the cities. And now, right after actually we closed our episode from this morning, there was a report from the Ministry of Health in Uganda that a case has occurred there of a Congolese person crossing the border and coming down with Ebola in Uganda. As you said this morning, Jess, that's the exact thing you were concerned about.
Literally.
I should add that one of the reasons why the West African epidemic became so large was that it started in a place in Guinea where there was a lot of cross-border traffic between Guinea, Sierra Leone, and Liberia, and people crossing back and forth actually for funerals of people who had died from Ebola ended up getting Ebola at these funerals because, as we discussed this morning, it's also very easily transmitted by contact with dead bodies. And that really amplified it. Eventually, it got into the cities. It got into Conakry and into Freetown and Monrovia, and that's where the West African epidemic went from being an outbreak to being a bona fide epidemic that ultimately more than 28,000 people were infected and 11,000 people died.
Yeah. It's this morning we talked about why the location matters. While it is happening in a remote part of Eastern Congo, where it's happening is in a mining town. Mining towns are known to be extremely transient because you have people who are workers who come in and out for the gig. It's not really a place where you can stay comfortably. It's not like a bustling community. And so because of that, there is a lot of movement. And so the case that has been identified in Kampala is evidence that this is somebody who was in and out. Now, Uganda has issued a national response. They are going to be sending out a bunch of tracers to manage the contacts of this person. They're going to be doing border crossing review, checking all the transit routes where people who would be coming from that area could be crossing, and if they had contact with folks, because again, they got to do a lot of backwards math here and figure out where this person was, how they got there, how many people could have possibly been on that same route as that person. And it seems like they're probably going to be shoring up a bunch of mobile labs to handle things like testing, quarantine, isolation, etc. It's any contact next to a deceased person would have to be quarantined. Quarantine requires a lot of infrastructure, as we are now seeing right now, even with the Hantavirus outbreak. We don't have those facilities everywhere, right? And Ebola is one of those types of diseases that is not just a typical room in a hospital that you would quarantine somebody. So Angie, since you have been in high security BSL containment labs, you understand that Ebola requires very specific attributes of a proper place to isolate and quarantine. Can you describe that?
Yeah, I mean, so the difference between working in a containment lab and a ETU or working in a patient facility is actually quite different. So I can't really comment on the patient facility aspect of it, but I can certainly comment on the fact that this is really to mitigate the same risk. And that is that even though Ebola is never going to be transmitted from person to person, as I said, it can actually be transmitted to a person via the aerosol route. So the first cells that Ebola virus infects in the body are called macrophages, and there are a lot that are resident in your lungs. They leave your lungs after they get infected, so that's why they're not still there shedding virus into your airway, but you can get infected that way. And in fact, I've worked on experiments where we experimentally infected non-human primates, and we could get uniform lethality in adult non-human primates with as little as one plaque forming unit. So that's one infectious unit of Ebola virus. That means that you are potentially very, very susceptible to developing lethal Ebola from very minimal aerosol exposure. The key is that people are not going to be transmitting it back and forth via that route, but you can get it that way. And so when you're looking at a patient room or an ETU, one thing that we've started to appreciate about Ebola virus disease, and we don't really know this about Bundibugyo virus, which is the particular type of Ebola virus that appears to be causing this outbreak, but I would imagine that it's probably very similar to Ebola virus and Sudan virus, these two other Ebola viruses that are better characterized. And that is that it's a gastrointestinal disease as well as a hemorrhagic fever. I think a lot of people think of hemorrhagic fever as, the hot zone kind of outbreak thing where there's blood everywhere. But in reality, hemorrhagic fever, most of the time, the bleeding is confined to gingival bleeding, bleeding around the gums, and petechial hemorrhaging, which actually looks like a rash. And that's because you lose essentially vascular barrier function and you start to get all these microscopic leaks from your blood vessels under the skin. So you're not gushing blood externally, but you're kind of gushing
Internally.
blood
Yeah.
internally. And then if you're vomiting a lot on top of that, you are creating aerosols. And the ETUs, the Ebola treatment units, in places, especially in remote places, are often very stuffy.
Yep.
They're tense. And that's why when you see the doctors and the nurses, and the clinicians caring for patients in there, they are wearing full kits. They're wearing PAPRs. They're wearing, they're not wearing a positive pressure suit, but they're wearing
Right.
essentially the field version of that.
Yeah.
And that's to prevent them from being exposed to those infectious aerosols that are created by people vomiting a lot.
Yeah.
So they do think that this is a potential mechanism for transmission, again, in certain circumstances.
Mhm.
And that, I think, has been a theme of this week, is when is a virus airborne? Is it
Yeah.
airborne because you can get it by inhaling it? I would say sort of.
Yeah.
But airborne to me implies that people can give it to each other by that route. And that's the thing that, as far as we know, anyways, Ebola cannot do. I think it's very implausible that it would do it just because of the biology of Ebola virus. But we've also been hearing a lot about this for Hantavirus, which
Yeah.
also can be transmitted by that route, transmitted from person to person under very specific circumstances, but it ain't COVID. And I think
Right.
that's been one of the really counterproductive aspects to this
Yeah.
discourse, is that we still don't know a lot about this, but we do have some evidence that neither of these viruses are more airborne than they used to be. I don't think we have any evidence that we should be expecting something like that. And I think it's really profoundly harmful to responses to say, well, you're not being scared enough.
Mhm.
I think that, these situations, I'm pretty scared, not because Ebola is going to become a pandemic, but because there is so much potential for massive loss of life. And I
Yes.
will never forget this, Jess. Like in 2015, there was a filovirus, Ebola viruses or filoviruses. There was a filovirus symposium in Washington, D.C., to go over lessons learned from the West African epidemic, which was still occurring at that time. And somebody from the Public Health Service posted a picture of actually the body control. So that, as we were talking about earlier, Ebola can be transmitted very easily from handling dead bodies inappropriately. So body hygiene, for lack of a better term, biosecurity and biosafety practices has been a big part of Ebola responses.
Yeah.
They showed a picture of dead bodies in the street in Monrovia. And like, that was the first time that I've ever cried at like a scientific conference. I mean, it was just one of the most striking,
Yeah.
horribly sad, just things that I've ever seen. And it's sad to me, especially because it's preventable.
Totally.
And that was in a situation where the US was very involved in the response. And I remember this too, because the filovirus meeting the year before that, in 2014, very early in the year, was in Galveston, Texas. And a bunch of people were unable to attend because they had just gotten on a plane to go to West Africa to respond to this weird Ebola outbreak that was occurring in a place that, we had never seen Ebola before.
Mhm.
And that was when the US had an active, pandemic response. We had a pandemic prevention plan. We were very involved globally in responding to these things. And now we're very clearly not. And I do have to wonder how much that has impacted the fact that we now have more than 300 cases of Bundibugyo
Mhm.
virus, and we are just hearing about it now.
I mean, let's talk about it. You mentioned things that are going to harm the response. The fact that, one, the Congolese government did not alert the news of this outbreak. It was the African CDC that sent the signal. Typically, the CDC would be like right after that. The CDC would be right there, probably in tandem with a local country issuing a declaration and with the African CDC. There are so many questions about this timeline, about when that first signal was sent, who received that signal, who ignored it, who potentially downplayed it and thought it was rumor, like we talked about this morning, because that seems to be like what could have possibly led to this massive, massive delay. And let's also just zoom out a little bit and see how we got here. One, there's no vaccine for this strain, as we know. part of that is because we are gutting infectious disease research. The systematic deprioritization of infectious diseases to somehow refocus on things like chronic diseases, forgetting the fact that that's a loop, inextricably linked loop of infectious disease to chronic disease. This is a reflection of this misdirection, a misdirection of funds, misdirection of research, misdirection of attention and partnership. Our isolationism is causing people to die. And I'm actually quite tired at this point of people saying nobody's really dying. This is a direct result of us abdicating our role as leaders in global health and health security. This is 100% on us. And the fact that we can't even see that USAID was an absolutely integral partner in specific things like Ebola management. It was USAID employees that would do things like, creating the systems for contact tracing, creating the systems for isolation and quarantine, education campaigns to teach people the proper ways to handle funerals while being culturally competent to manage things like grief, right? You're dealing with different religions in this area with very different burial practices. So if you have people from different religions who do things differently and require much more hand holding or close contact, it's unbelievable that we would just say, you know what, they're going to figure it out themselves. I'm going to have to pause for 1 second. I'll be right back, Angie, but take it from here.
Yeah, I will. No problem. Yeah, that's a great point. I mean, I think that, we've talked about how dealing with corpses and body control and burial has been a really critical part of controlling Ebola outbreaks, as has vaccination, which I'll talk about in a moment. But that requires a cultural understanding and a cultural sensitivity, because you're not just talking about getting rid of waste, you're talking about people's loved ones and members of their communities. And I think, that's something that we in the US, working with the international community, invested a lot of effort in to make sure that, we're teaching people how to bury the dead safely, but we're also being conscious of the fact that these are their family members, these are their neighbors and their loved ones, and they have to be able to bury people within the cultural context and the religious context, and spiritual context that they live and work in. I mean, the thing I think that people aren't understanding is it's not that the US is not available to parachute in. The US, as you pointed out, with USAID and other programs, including NIH funding, has been really responsible for a lot of infrastructure building in these places. And that doesn't mean sending Americans in to do stuff, although there's still, unfortunately, too much of that. But it means sending Americans in and people who have experience dealing with Ebola outbreaks, and actually training people so that they can then turn around and provide that service for their own communities and take care of it in the future. And we were pretty successful in doing that, actually, towards the end of the West African Ebola outbreak. And this is where vaccination comes into it. We had developed these Ebola vaccines, and actually they were first developed in Canada at the National Microbiology Lab in Winnipeg. But then they moved development down to the NIH, Rocky Mountain Labs. And then those vaccines just sat there for a long time because not that many people get Ebola. It's very difficult to do clinical trials on vaccines if nobody's getting the disease. And that's one of the ironies of needing evidence before we approve vaccines, is that you actually have to have people getting the disease before you can tell if the vaccine is going to work to prevent it. And the West African outbreak was, well, there's one other issue too, and that is that the vaccines are by no means profitable, because even though it seems like we always hear about these Ebola outbreaks, Ebola is actually a quite rare disease. It's certainly not going to be a cash cow the way that, COVID vaccines or something are, where everybody in the world's going to need it. This is a vaccine that you develop for humanitarian reasons, because you don't think that people should die from a horrible disease that they don't have to die from. And so these vaccines sat in this sort of purgatory for years until the West African outbreak happened. And then they said, well, we've got these vaccines, let's try them out. It still took several years, and the international community, working very closely with the Congolese Ministry of Health, to put together a vaccine trial that was ethical, that would provide the most benefit for the most people. And it did. It showed that vaccine works very well to prevent and contain Ebola outbreaks, because they use what's called a ring vaccination strategy that expands outward through contact tracing and eventually vaccinates everybody so that the outbreak can't spread further. We could do that with Bundibugyo virus because we do have some vaccines in preclinical development, but they have stalled as well. And so, it took 2 years to get the Ebola vaccine for Ebola virus, which is related, but not cross-protective against Bundibugyo, which is causing this outbreak. And we would have to do the same thing with the Bundibugyo vaccine, but I don't see how we could possibly do that when we're talking about a situation where, hundreds of people have been infected, more than 50 people, 65 people, I think is the count now, have died. And we're just finding out about it now. How do you do anything where you have to design a clinical trial that requires that much coordination and that much funding? The US is withdrawn from the World Health Organization. We are no longer participating in any of this stuff. And in years past, when that vaccine was developed, there was another Ebola outbreak in the Democratic Republic of Congo in an area that in North Kivu province where there was a lot of security issues and there was some civil war. There was civil war, basically. And it made it really dangerous to actually do outbreak response. And the U.S. was instrumental in bringing some of those vaccines. We actually had U.S. federal employees helping with the Ebola response who were literally carrying some of these vaccines to the site and providing them to clinical workers who were then administering them to people. And we have nothing like that now because many of those employees from the federal government have lost their jobs and they're not there anymore to do that. Not to mention that this administration isn't going to fund anything like that. What they're doing instead is they have a penile implant surgeon leading the Hantavirus response. And this is a guy who, traffics in conspiracy theories. And again, his expertise is surgically enhancing penises. Yeah. It has nothing to do with Hantavirus or Ebola virus or any of this stuff. I mean, the people running things don't know what they're doing. And that's intentional, I think.
Yeah. Yeah. So, I mean, to contextualize this again and to reiterate what we said this morning when we gave you the first news of this outbreak, this does not likely have pandemic potential. We don't want people to start panicking. It is concerning for the reasons we outlined earlier, that it got this big, this fast, and that we're just hearing about it now. This many deaths and this many suspected cases with only a small number of laboratory confirmed cases are all red flags to what is a obviously under-resourced system that is in the region at the moment. But again, we do not think that this has pandemic potential. It is quite concerning that it has now crossed over to Kampala. Kampala is a very international. I have been to Kampala multiple times and I have flown through Kampala multiple times. So because of that, they are going full court. How can we make sure that we make sure that our points of entry and exit are secure? So they're doing the best they can with as much as they have to control this and make it not spread further. And we'll keep you updated. I mean, I think at this point, all we can say is this is what we know. There's a lot that we don't know. But what we can do is contextualize it for you and say, this is, again, what it's revealing is less of a threat to every person on this planet, but more of a threat to our total global health security. A disease threat over there can be a disease threat here with one person, but also when countries are destabilized and this acutely harmed by preventable diseases, it's a shame on all of us that this would even happen. This is a completely preventable amount of loss and suffering, and it's probably going to get worse before it gets better at this point because we just found out about it.
Yeah, and I mean, I think it's absolutely going to get worse, and unfortunately, I think we're in a position where now we're going to have a bunch of people who just heard about this virus mispronouncing the word Bundibugyo, and I'm not even sure that I pronounce it correctly because I've also heard it the way that you pronounce it, with the hard D.
I've heard of those, yeah.
Yeah, I mean, it's, there are a lot of Ebola viruses. I think that people, they only hear about Ebola, and it's kind of the rock star of viruses because it just gets so much attention. But, it doesn't matter if it's Ebola or Sudan virus or Bundibugyo virus. I mean, these viruses all cause the same thing. And as you said, that's tremendous suffering. I think the biggest problem I have with the discourse about both this Ebola outbreak and the Hantavirus outbreak is the idea that we don't have to care about it if it's not happening in America, if it's not happening to Americans. Who cares? I've had so
Yeah.
many people tell me on social media, oh, it's only a problem if you're going to like this shitty corner of the DRC. Well, I'm not planning to go there, but that doesn't mean that I don't care. I mean, Ebola researcher, the reason I study Ebola, besides the fact that it's intellectually fascinating to me as a virologist, is that Ebola scares the hell out of me, and it's horrible for anybody to die from it. It
Yeah.
seems like an absolutely terrible way to die. And if we can prevent that from happening, we
Yeah.
should do that because it's the right thing to do, not
Yeah.
because it's going to affect us personally.
Yeah.
And I think people did see during the West African epidemic, because we did have some cases coming back. I've spoken with multiple Ebola survivors from that outbreak who were doctors, Craig Spencer and Ian Crozier, who were doctors who were infected, treating patients in West Africa. And I mean, Ian in particular really almost died. It's a miracle that he didn't. And the only reason he didn't was because he got world-class supportive care at Emory University,
Right.
as opposed to dying in Ebola treatment unit in West Africa, which is the fate of most of the people who do get it. And I think that as long as we are moral people who have a sense of what's right and wrong, we do need to care about this. And
Yeah.
if you're just completely selfish, okay, fine. You're probably not going to get Bundibugyo virus. But what happens when it's something else? What happens when it's SARS coronavirus 3? What happens when it's MERS coronavirus 2? What happens when it's H5N1 that makes
Yeah.
the leap?
Yeah.
That will affect all of us. And
Yeah.
it's just a plane flight away. In case of H5N1, it's just a bird away.
Yeah.
You know, it's something that affects all of us. We are a global community, and viruses regard us that way. We are a global community of hosts as far as they are concerned. We should really start thinking of ourselves that way, as a global community of people who need to come together to make sure that we're all taken care of,
Yeah.
whether we live in the DRC or the USA.
Yeah. I had someone just ask me, isn't this a category A bioterrorism threat? Yeah. Okay. Just want to level set with some terms here. So these are terms that we use a lot in our space. It was, very important when I was doing early biosurveillance 20 years ago, how we categorize these diseases. Ebola is a category A priority pathogen, as designated by the US government and many other global governments. And the reason for that is it has a high mortality rate. It has not large amounts of treatments. A lot of times it's supportive care. And the places in which it happens, a lot of times they don't have access to those types of treatment. The route of transmission is concerning. It can be very, very high case counts in the context of burials and in managing death. That does not mean that this is going to be a pandemic, and it also doesn't mean that it is going to be weaponized. It's a way in which we categorize risk, and because this disease doesn't have the arsenal of response tools that we have for many other diseases, we feel more vulnerable to a disease like this, that we don't have as many tools in our toolkit to fight against, whether via vaccines, whether through treatment, or whether through control measures. What would you say to that, Angie?
I mean, I completely agree with that. And to a degree, it's changed for something like Ebola virus.
Right.
I don't think it's ever going to be demoted from
No.
category A or being a select agent. But Ebola virus itself now does have vaccine. There are monoclonal antibody treatments that do work. But as you said, I completely agree with that. It's not like people are getting infusions of monoclonals
Right.
at every ETU. They're not getting IV fluids. I mean, they're not getting basic supportive care. And so for that reason, the vaccination campaign was really critical, because that is something that's affordable. And with the US's help, and with the World Health Organization, and with Africa CDC, with MSF, and all of these organizations, we've been able to deliver that protection to people in Ebola outbreaks, but it doesn't help the people who've already gotten Ebola.
Yeah.
And I think people really need to understand that that only applies to Ebola virus. So there are 6 species of Ebola virus. Thai forest used to be called Cote d'Ivoire. From the Ivory Coast, that's infected one person ever, who was a chimpanzee veterinarian necropsying chimps that were dying from an Ebola outbreak in a national park. That's probably not a huge pandemic risk, but it's still regarded this way.
Right.
Then there's Bundibugyo, Sudan virus, and Ebola virus. Those are the ones that do cause disease. Then there's Bundibugyo, which we don't know if it causes disease. There's Reston virus, which we don't think causes disease, but it could. We don't want to find out. So that's why all of those things are treated that way. And they're still treated very seriously because the consequences are so severe. And as you put it, it's a way to measure risk. It's not a way to say, oh, hey, terrorists, come get some Ebola virus. It would be a great bioweapon.
It would be a terrible one.
It's a terrible bioweapon. Yes, and I think anybody who saw what happened during the West African epidemic can see that it's a terrible bioweapon, because the reason it spread like that had to do with a failure to respond effectively and contain the outbreak to begin with. It's not because Ebola itself is such a scary pathogen that it can overcome these other measures. It is a scary pathogen in the type of disease that it causes. Hantavirus as well. I mean, I've been telling people, like, don't worry about hantavirus because you can prevent yourself from getting it very easily. I would definitely worry about hantavirus a lot if I had hantavirus, because it has a very high mortality rate.
Absolutely.
And the same thing's true for Ebola. But just because something's deadly doesn't mean that it's automatically also a weapon, or that it could even easily be used that way.
Yeah. This kind of brings up the whole risk versus hazard conversation, which we can get into another time. Let's spend the last couple minutes maybe just giving folks the update, which is not a huge update about hantavirus. Not much has changed since we last updated you all. It seems that there are 41 people across the United States under monitoring protocols for hantavirus. The number of people who have tested positive has not grown since the last time we updated. The doctor who had initially tested positive is now negative. We've got that wonderful guy who is sharing his updates from his quarantine, which I think is completely elective because he's asymptomatic and not positive. But I love the updates that he has been giving, and even just celebrating the tiny treats that he got, like a Starbucks coffee for the first time in 6 weeks. So, again, I don't, do you have any updates beyond that?
Not really. I mean, I think the one thing that I just keep thinking about is there's been so much discussion about, it might be more airborne than we think. That's really based on, I think, a lot of speculation and overinterpretation of a single paper, and actually a single figure in a single paper.
Right.
I think that, we need to be really careful about being selective like this. I'm all for the precautionary principle and taking adequate precautions, but I don't see any evidence that we need to take precautions beyond what has previously been used to control hantavirus outbreaks. And again, it's not actually very transmissible, except in certain circumstances. We can avoid those circumstances. But what I think we can avoid, there's been all this discussion about, it was reported that so-and-so sat next to so-and-so on the boat, and that must be when they got infected. As far as I'm concerned, the quarantine, the incubation period should start the second that those people all got off the boat.
Yeah,
because I don't think we have any idea what kind of interactions or conditions there were on the boat that led to person-to-person spread. But I do feel pretty confident they were on this boat for a long time. And granted, hantavirus has a long incubation period, up to 40 days, which is quite long. But that has been passed for some of the people. Some of them have, obviously become ill already and died. I think all of the other people on the boat, they could have been infected by person-to-person transmission at any time, because we don't know what these conditions were like. And so for that reason, they should be quarantined, or at least self-monitoring. And it sounds like, that whole separate situation has been, what are they going to do? I don't know, which makes sense, because now we find out that a penile enhancement surgeon has actually been running all of this. So I don't know, maybe he thinks, like, you just make it bigger and harder and longer, and, that'll fix it.
Wasn't ready for that visual, Angie. But on that note...
You know what? I got 1 hour of sleep last night, and I'm in Asia right now, and I'm not taking shots because it's 5:30 in the morning. So I'm drinking a can of water. Although a couple hours ago, I was drinking a can of pretty terrible Chilean Sauvignon Blanc. in honor of Andy's virus.
Oh, wow. 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 Well, I'm going to stay hydrated and stay focused on these headlines as they emerge. As always, our DMs are open, our inboxes are open. So please send your questions. Angie, I don't know if you want to continue on here, but I have to bounce to another call. Thank you guys for joining us. We wanted to keep this short and sweet so that we gave you the most important updates about these two things. But in both scenarios, we're telling you not to panic, but to be concerned about the state of public health and global health security, because when people are suffering elsewhere, we're not separate from them. We're all connected. So
yeah, I think that's absolutely right, Jess. I'm not going to stay on either because I'm actually deliriously tired, and I have to give a talk in about 8 hours that I haven't finished yet on U.S. vaccine policy to explain what the hell's going on to all of my colleagues here. So I'm going to go maybe have some coffee or something to get ready for that. But I wanted to say also that, if big things come up, I'm certainly available on and off to come on and talk with you about them, Jess. And
always.
we will get our colleague Saskia on here. We've got a lot of colleagues actually who do work on Ebola, who work on Ebola response. And we're going to try to do more with them. Working with the Save America movement, I'm the science chair for that. We really want to have an initiative to draw attention to what the U.S. has done by not doing anything.
Yeah.
And I think that this is a really important conversation to continually have, especially because there is increasingly so much disinformation in this space.
Yeah, that's right.
So it's great, as always, Jess, to see you and to chat with you about not great things. But at least if we have to talk about it and deal with it, it's good to be doing it with good people who know what they're doing.
Thanks. It's great to see you, Angie. So grateful for you that you're doing this at any hour or time zone too. That is quite the commitment to the cause. So thank you. Get some rest and also crush your talk. I know you will.
Yeah, I will. It's the great thing about being an insomniac. I get a lot of work done.
It's true. It's true. All right, everyone. We'll see you
have
next
a great
week.
weekend, everybody.
Bye.
As Jess said, stay in touch. We'll see you later.
Bye.